I am Bill Block, for those of you I haven't met. I am currently the chair of the OBGYN department for my tenure of a little over 2 months. I am a Quillen grad from a few years back, and went off and did my residency at the University of South Carolina. Did a maternal fetal medicine fellowship at Wake Forest. Came back to ETSU on faculty in '98 for 6 years. Division, and then went to Minneapolis for 11 and a half years, where kind of my career devolved into dealing with a lot of multiple gestations and kind of a niche market of multiples and twin-to-twin transfusion. So this morning I'm going to talk kind of the basics of twin gestation, get into twin-to-twin transfusion syndrome and how that's treated, and hopefully highlight that multiple gestations are not certainly the same as singletons, and the risks and everything else involved with that are much higher. And then we can all cost Dr. Ransom about any multiples he may cause. Wrong button. Not operating, I'm not. I have no conflicts of interest in this. What's the first question anybody comes in when you tell them they have twins? They want to know, are my babies identical? Most of the time we can tell them. It is one of the most important questions, not only for the patients just in their interest, but it's also one that should be one of the most important questions for the provider, because it very much alters the risks involved with the pregnancy and how you're going to manage the pregnancy. Today we're going to try to understand the importance of determining chorionicity, talk about some of the pathophysiology of twin-to-twin transfusion syndrome, and what the current treatment options are that we can use. This is a quote that I have pulled from an old book, and I like to use when I'm talking about things that involve either fetal intervention or kind of some of the impacts we can have on pregnancy. And again, it just highlights something that we're becoming more and more aware of as we go on, that a lot of what occurs in utero sets up things that are later in life. And so chronic hypertension, diabetes, many of these things are probably, if not triggered or pre-programmed, they're certainly contributed to by things that occur while we're still a fetus. What is the mechanism of twinning? Well, most twins, about 2/3 are dizygotic. So mom managed to ovulate twice during the same cycle. Both of those were fertilized and have implanted, so we have non-identical dizygotic twins. The rates of those are pretty standard in the fact that they increase with age. They peak at about the 35 to 40 age range. They do decrease after 40, as with all parity. But regardless, I mean, with all fecundity, as we see people who have more babies, so your higher multi-gravid patients are more likely to come in with twin gestations as they get pregnant in that 35 to 40 age range. There are ethnic differences in the amount of twinning. There are family differences in the amount of dizygotic twinning. There's a tribe in Africa that has apparently about a 5% twin rate. So certainly they can vary across the country, across the world. Monozygotic twinning, if left alone, is much more standard. It's about 0.4%, so 4 in 1,000 pregnancies will result in monozygotic twinning. It's not influenced by location, ethnicity, or anything that the mom did. It is influenced by ovulation induction, which will triple it, and advanced reproductive technologies may increase it eightfold. So maybe 3% of ART patients that have monozygotic twinning. The incidence of twinning in the last 30 years has skyrocketed. The reasons for that are probably about 1/3 of this increase is related to changes in the pattern of maternal age across the spectrum. So we see more women that are having babies in that upper 30 age range, so that increases our rates. The other 2/3 contribution is probably due to increased assisted reproductive technologies. In 2007, 140,000 twins were born, 32 per 1,000 live births. There were about 6,000 pregnancies with triplets, 370 quadruplet pregnancies, 91 quint pregnancies, and none that were recorded as being higher than that during that year. During 2006, this was one of the sextuplet pregnancies, 6 fetuses, uncontrolled ovarian stimulation by general obstetrician. It subsequently resulted in 6 babies making it to about 15 minutes shy of 23 weeks until her labor was unable to be controlled anymore. We called in 6 neonatal resuscitation teams and delivered these babies. 1 baby went home from the NICU. The other 5 did not survive. In 1980, 1 in 55 births was twins. That's almost doubled by 2010. 1 in 31 births. 26% of IVF pregnancies were twin gestations in 2004. How do we approach twin gestation? Ultrasound is really the mainstay diagnostic test that we do throughout pregnancy for twins. Early on, we need to determine, are they sharing a placenta or are they not sharing a placenta? How do we do that? The thickness of the membrane is a good key. Whether there's a twin peak sign to show us that there is placental tissue up between that membrane, showing us that it's in fact dichorionic, and in fact that they're in separate sacs. All twins need targeted anatomic surveys at risk of chromosomal abnormalities increase, and serial evaluations of fetal growth with antenatal testing are recommended in all twin gestation. So dizygotic twinning. Separate sacs. Essentially, 2 pregnancies occurred in the same uterus at the same time. 2 chorion, 2 amnion, resulting in a thick membrane. Placentas may be abutting each other, or they may be on separate sides. Down here. As these grow, they may abut and look to be one fused placenta. Typically, early with ultrasound, we're able to see that that's not the case. Certainly, the biggest giveaway with dizygotic twinning is that they're separate sexes, which tells us for sure that they can split as they make.
I've had that way.
If I could work the pointer, it'd be in better shape. So, 2 separate sacs, a little bit of fetus on each side, nice thick membrane between, twin peak sign, with tissue coming up between that membrane. Definitely a dichorionic pregnancy. Antenatal management is different between monochorionic twins and dizygotic twins. Okay, monochorionic twins are different. Initial scanning, we really want to know in the first trimester whether these babies are monochorionic or dichorionic. If the pregnancy is going well, we start scanning every 2 weeks, starting at 16 weeks. If there's no discrepancy in amniotic fluid, they can be followed every 2 weeks. Whether umbilical and middle cerebral artery Dopplers need to be added to that scanning really depends on who you read and what the availability of them is in your community. We, of course, did everything because we had the technology and it's what we were looking for. You will find early evidence of twin-to-twin or early evidence of twin anemia polycythemia sequence if you do the Dopplers. We don't know that intervening earlier makes any difference. So, still an unanswered question. Growth every 4 weeks to determine if we're having a discrepancy in fetal growth, and weekly antenatal testing to begin at 28 weeks. So, monodiad twins really project as well as it could. 2 babies, 2 sacs. Membrane between and thin, not projecting well. No evidence of tissue up into the membrane. So, divided into monoamniotic twins. Congenital heart disease certainly increases with monoamniotic twins. Likely there's an increase with dizygotic twinning as well. Important to get fetal echoes or at least a nice targeted scan to make sure you're on flow track so that you don't have a significant structural abnormality in the babies. ACOG has come out with kind of practice performance measures, and it's one of those things that they're going to, at some point, probably look at to see are we practicing in the manner that we should be for reimbursement and for everything else. And one of their performance measures was the proportion of women with twin gestations who present for prenatal care prior to 16 weeks who have chorionicity determined. It's not at all uncommon that you'll see an ultrasound report on somebody at 20 weeks from different radiology departments or OB offices that say twin gestation, normal growth in amniotic fluid, give you some anatomic markers, and not have any comment as to what the chorionicity is. Come back in 8 weeks. Those are disasters waiting to happen. Most of the time you get away with it, but really it's important to know what the chorionicity is and to follow them so that you can determine if there's become an issue. It is nice to know that we have twins over a singleton. Certainly the nutritional requirements are different. The amount of iron supplementation is different. The amount of folic acid supplementation for mom's health is different. You're not going to impact whether you have a neural tube defect, whether you increase their folic acid supplementation by the time you determine that they have twins. Their neural tube has already done what their neural tube is going to do. You don't really need to take 2 prenatal vitamins or anything else from the fetal standpoint. Maternal risk. You're 6 times more likely to be hospitalized if you have a twin gestation. You're at more risk of preeclampsia, preterm labor, pyelonephritis, postpartum hemorrhage, gestational diabetes, increases with the number of babies you have and the more placental tissue that you have. Thromboembolic disease becomes worse because you're more likely to be at bed rest, you're more likely to have a very large pelvic mass that's going to inhibit your return flow. Delivery less than 32 weeks gestation. Certainly all preterm delivery should be avoided if we can. When do we get most concerned? Certainly the earlier the delivery, the more concerning it is and the more chance of having long-term neurologic injuries. Singletons deliver prior to 32 weeks, a little bit more than 1 in 100. Twins, it's about 1 in 10. Triplets, about 1 in 3 are going to deliver before 32 weeks. What does that cost us? The maternal and delivery care in 2010 estimated for a singleton pregnancy is about $21,000 nationally. If you have twins, that goes up to $105,000 by the time you get those babies home. If you have triplets, it's estimated to be $400,000. That's just to get the babies home, and that was in 2010. My suspicion is when I updated this talk, my prior data was 2007, which estimated that triplets were at 250,000. Probably that increase in rate is still going on, so we're probably closer to 600 for triplets at this point. Busy slide, and I apologize. Kind of looking at the averages as we go up in gestation. So twins, triplets, quadruplets. What's the average birth weight? We've gone from 2,300 grams down to 1,300 grams. 35-week gestation down to slightly under 30 weeks gestation for your average delivery. Percent with growth restriction, somewhere between half and 2/3 of the quads. Neonatal admission, quads 100%. Average length of stay in the neonatal intensive care unit. This is where your costs add up. Average of 2-month stay for the quads. Risk of cerebral palsy. Twin gestation, 4 times more than singletons. Triplet gestation, 17 times more than singleton, with a 20-time higher risk of death by age 1 for triplets. Asymptomatic patients in preterm labor with multiple gestations. We have for years tried to predict who's going to have a baby early and how can we stop it. Home uterine activity monitoring. I don't know if you all are seeing that or have any history with it anymore. At one time it was a huge industry. It costs about $1,000 a day to put somebody at home on their home uterine activity monitoring. It didn't make any difference, but lots of people used it, and lots of home health agencies would come by and give you literature and promote their use of it. But it unfortunately doesn't make any difference. Other screening methods didn't impact the ability to keep people pregnant longer with multiple gestations. Positive predictive value of fetal fibronectin or short cervix is poor, should not be used exclusively in the management of patients. So doing fetal fibronectin screening on somebody that's an asymptomatic patient is really not recommended and really doesn't add anything to your care other than cost and a lot of anxiety. Prophylactic cerclage has not been shown to be beneficial. Cerclage for cervical shortening may actually increase preterm birth by 2.2 times in a multiple gestation. So while we see that occur, it probably is not the way to go. Preterm birth prevention, again, bed rest, no improvement. We can sit here and spend the rest of the hour debating whether bed rest or decreased activity or any of those types of things contribute to longer gestational ages, but it certainly hasn't been shown to be of any great benefit. Prophylactic hospitalization. There was a time we used to admit every set of triplets or higher into the hospital at some magical gestational age, depending on what provider you were, was how you set your gestational age, may have been 28 weeks, and they just laid in the hospital. And that was an idea to keep them pregnant. It really doesn't work. Prophylactic tocolytics, we don't have anything that works long term. Pessary has really not been shown to be of any benefit. And progesterone really hasn't been shown in multiples to do anything either. If we do have preterm labor, tocolysis with calcium channel blockers or non-steroidals, indomethacin may help for the short-term benefit of achieving steroids. Betamethasone has been the biggest advantage that we've come up with for all preterm births, decreases neonatal death, decreases RDS by at least a third, decreases interventricular hemorrhage, and improves NEC. Magnesium sulfate has been shown to decrease the risk and the severity of cerebral palsy if administered to babies that are going to be born prior to 32 weeks. So, certainly, MAG for anybody delivering before that age is indicated. Monoamniotic twins. So, somewhere my slide disappeared that went through all the descriptions as to when we cleave and when we decide and when we wind up as a monoamniotic.
It was earlier. It's like your fourth slide.
Oh, was it?
Yeah.
I zoned on it?
You're ready.
Okay. I'll go back to it because I actually remember it. So if we're a monozygotic twin and we cleave prior to 3 days of gestation, we wind up appearing just like a dizygotic twin. In that 3 to 8 day range, we're in separate sacs, but we share a placenta. So monochorionic diamniotic. If we're in that, I'm going to zone on it and even forget what it says. If we're in the 8 to 13 day range, we wind up with monoamniotic twins. And so not only do we share a placenta, but we share a sac. Incidence of that is about 1 in 10,000 pregnancies. Again, increased with the evil reproductive endocrinologist, unfortunately. Loss rate quoted as high as 80%. We tend to quote to patients that it's probably 50% from the time you reach viability. You may still have half of those babies not make it home from the hospital. The incidence of cord entanglement and injury, either due to cord entanglement or death due to that, is primarily what causes the majority of loss of monoamniotic twins. There certainly is twin-to-twin transfusion syndrome that also occurs in monoamniotic twins, but it's very difficult to diagnose because we don't have the differential in amniotic fluid volumes. So we're stuck in those babies really looking at Doppler flows, looking at liquid bladder fills, looking for advanced stages of disease, and it's much tougher treatment. Most of these babies or moms are admitted for fetal monitoring at some point during their pregnancy in an effort to try to determine if cord entanglement is putting these babies at risk. Whether you admit them at 24 weeks, 28 weeks, 23 weeks, nobody really knows. And it really depends on mom's desires and what risk mom's willing to tolerate from home. There's also not good evidence that we really do a whole lot different in outcomes by being in the hospital versus being at home. And it makes you look a little foolish when you have somebody in the hospital and you're doing 3 times a day monitoring only to have a precise time of death for a set of twins. And it happens, and there's really not much you could do. Continuous monitoring makes staff and the patient insane, so you can't do that, but what the correct monitoring is, nobody knows. There was a paper that came out of the University of Iowa that said by the time babies get large enough that they can't entangle much more, that it's much safer to go later in pregnancy. And their contention was that from 34 weeks on, you didn't need to worry as much about these babies. That paper was retracted in the following month because they had a loss of 35-week twins. So we really just don't know. We delivered most of these and still think that probably the right delivery time is somewhere in the 32 to 34-week range. Certainly 2 babies out in the NICU at that rate, that age should do well. Acardiac twinning, essentially monochorionic twin gestation with the loss of 1 twin, resulting in the surviving twin being the pump twin, and reverse arterial perfusion to that remaining fetal tissue. Again, 50% loss rate, resulting really from cardiac overload in that pump twin. So, again, measuring the amount of fetal tissue that's there and determining if that baby's at risk and whether an intervention to try to occlude those vessels is worthwhile. Conjoined twins, estimated 18% survival. Again, no good numbers as to whether that is too high or too low. I think in the however many 2 or 3 years I've been doing this, I've probably encountered 1 surviving pair of conjoined twins out of about close to 20 that were non-survivors. So I think that's probably an overestimate, and it's probably for those that get up into the 2nd and 3rd trimester, that may be realistic. But most of these share a heart, share a chest, and are offered termination earlier in pregnancy. Delivery timing, dichorionic twins. Reasonable if things are going well and mom's status is stable and babies are well grown to deliver at 38 weeks gestation. Dr. Jernigan's grandbabies are a good example of how 38-weekers do, and he's got proud pictures that he'll show you later. Monochorionic twins. We had chosen to deliver these babies at 37 weeks in Minneapolis because it was the balance where we thought these babies were going to do well and not have as much continued risk of twin-to-twin transfusion. There are papers all the way from a group in the Netherlands that says we should section all of these at 34 weeks, to others saying that we can go 38 weeks just like dizygotic twins. And again, monoamniotic 32 to 34. How do we deliver these babies? This is a statement from ACOG, and it's one of those that can certainly be interpreted in many ways, but they kind of send out things that in diamniotic twin pregnancies at 32 weeks of gestation, the implication being prior to 32 weeks, it's tougher to deal with the 2nd twin, and they may be more risk of vaginal delivery. But at 32 weeks or later, presenting baby vertex, regardless of presentation of the 2nd twin, vaginal delivery is a reasonable option and should be considered. Okay, you can consider it a lot, provided that an obstetrician with experience in internal pedalic version and breech delivery is available. How many of the residents have done an internal pedalic version? How many of the attendings have done an internal pedalic version? Okay. So, but how many have you done? And at what point are you experienced in an internal pedalic version? I've done, I don't know, a couple hundred 2nd twins. I think I've probably done an internal pedalic version less than 3 times. I can do them. I guess I'm experienced in doing them. Much more likely that I'm going to do a breech extraction on a baby that's lying transversal will give you the feed. But you kind of got to be careful in the fact that you also need to be experienced in breech extraction. You probably should be comfortable with Piper forceps. Or you probably need to call somebody that's going to stand at your shoulder. And I'm happy to do them. I'm happy to come in. I came in before when I was here and did them. I went in Minneapolis and did second twins. I like to do them. It's probably one of my bigger causes of angina, but it's a good delivery to do as long as things go well. If you're out by yourself and you don't have backup and you don't have experience doing these things, the safest thing for mom and baby may be to deliver by section. And we deliver lots of babies by section for lesser reasons. So healthy mom and healthy baby is the goal. Advertisement, where it used to be. Twin-to-twin transfusion syndrome occurs only in monozygotic, monochorionic diamniotic. It's an older slide. We weren't as focused on monoamniotic twins at that time having it. A third of all twins are monozygotic. 2/3 of monozygotic twins are monodi. So that means 20% of all twins are at risk of twin-to-twin transfusion syndrome. We get about a 15% incidence of twin-to-twin transfusion syndrome in monodi twins, which means 30% or 3% of all twins will develop twin-to-twin. It accounts for 20% of all perinatal mortality in twins. So very disproportionate perinatal mortality for a disease that only occurs in 3% of pregnancies. 15 to 20% will develop the unbalanced perfusion. It is not inherited. It is not caused by mom or dad. And that's the biggest thing that we saw with patients. And there's this idea that I've done something to my pregnancy to result in this. The best thing you can do is reassure them that it really is a natural thing that has occurred. Kind of a cool diagram that we stole somewhere. So donor twin on one side, really wrapped with the membrane. No more amniotic fluid around that baby because it's spending all of its time perfusing to the recipient twin, which now has polyhydramnios. Oftentimes this donor twin is smaller. There's an issue as to the chronicity of twin-to-twin transfusion syndrome. If it occurs acutely, these babies may be totally the same size, but have significant shifts in amniotic fluid. If it's a more chronic issue, or if it's coupled with selective intrauterine growth restriction, then that donor twin may be smaller. There's probably some mechanism of selective growth restriction that increases the chance that that baby is going to become a donor twin, but we don't know the mechanism of how that works. If we take monodi twins, almost all of them share vascular communications across the placenta. It's in the neighborhood of about 97% if you do injection studies on the placentas. The nice thing is that almost all of those connections are surface vessels. What do we most likely see with ultrasound? We look, our initial view, we see some baby that's got a lot of amniotic fluid. We look on the other side of the uterus and we see a baby that's stuck and doesn't have any amniotic fluid. Stuck twin, it may be anterior, maybe stuck to the top of the uterus. Babies, just like all the rest of us, have to follow the rules of gravity, unless there's a reason that they're not. So if they're stuck in the uterus and you roll mom around and you still can't find the membrane, it's more than likely that that baby's stuck there because there's no amniotic fluid around it. And it's not as likely that it's a monoamniotic gestation. Ruben Quintero is a gifted, talented physician that has come up with a staging criteria that he continues to hold very steadfast to. And we all use it as a marker of how severe twin-to-twin transfusion syndrome is, but it's been adapted like most staging systems by anybody that uses it. In the most basic form, which is what he came up with, stage 1 twin-to-twin transfusion syndrome is really oligohydramnios and polyhydramnios. Less than 2 centimeters is always oligo in your deepest vertical pocket. More than 8 centimeters under 20 weeks, most of us will use 10 centimeters, 20 weeks and above for when you have a definition of polyhydramnios. When that progresses to where you no longer see the bladder in the donor twin, and that baby's making less amniotic fluid, it's then a stage 2 disease. Stage 3, we have abnormalities in our Doppler flow, or changes in our cardiac function of either twin. Stage 4, one or both babies is hydropic, and stage 5, one or both babies have passed away from the disease. When we first started using this staging system and looking at it, we really wanted to believe that patients went from stage 1 to stage 2 to stage 3, like we want to believe they do in most cancer staging. It's really not that simple. You'll see a patient that's a stage 0 and just has a little amniotic fluid discrepancy, that the next time you see them will have a stage 3 disease. You'll see others that will be stage 3 and go back to stage 1 and jump all around the spectrum as to the severity of disease. For those of you less experienced with ultrasound than the students, so Doppler flow of the umbilical artery, peak in flow with systole, and then continued flow at diastole as the heart relaxes. Let's still forward flow. As we see increasing pressures in the placental bed and increasing pressure in that umbilical artery, we get these jets of flow with systole, and you get absent in diastolic flow as the heart relaxes. Typical placenta with injection studies to look and see where the vascular communications are. The membrane in this one has been removed so that you're able to see better, but falls right here. A little bit of difference in placental share for each of these babies, but you can see these are the vessels that will typically go across this midline and communicate with the other gestation. If vessels are behaving, then they're paired. They come out, turn around, and come back to the cord insertion of the twin. Twin-to-twin transfusion syndrome, if it occurs prior to 24 weeks and is left untreated, you'll have a fetal loss rate of 80 to 90%. Not a good disease to have. If one twin dies because there are vascular communications between those twins, about 35% of surviving twins will have a neurologic injury. How I was taught to treat this disease was that we decreased the amount of amniotic fluid around the baby that was the recipient, because that was going to help prevent preterm labor and was somehow going to change the dynamics of how things were working in the placenta. So that was really all we had to do. You hooked them up to a big vacuum tube, took out a liter or 2 of amniotic fluid, brought them back in some unprescribed time, either 2 days, 3 days, a week, and took more fluid out. And kind of continued that process until mom either delivered or you lost the babies. I had a patient probably around 2000 that I believe I did 17 amniocentesis on was labor and delivery, to a total of something like 36 liters of fluid removed. And she still sends me postcards from her baby. She made it to about 32 weeks till she ruptured membranes and delivered. Did we impact the disease at all? Probably not, but she didn't become as distended as she otherwise would have. Studies as to survivorship with amnio reduction range all the way from 30% to 80%, depending on which study we decide to read. Probably about a 50% chance of one baby surviving to 6 months of age. So over half of these will not even be that likely. We'll have more loss. 25% of survivors will have long-term developmental delay. How much the twin-to-twin transfusion syndrome contributes to that developmental delay is really up for debate right now. There really is no longitudinal study that looks at developmental outcomes of monochorionic uncomplicated twins. So if you start digging into the literature and testing all of these babies with the test that the developmental pediatricians use, it's probably 20% of all monochorionic twins have some developmental delay that were uncomplicated. So 1 in 5 just from splitting your off from your co-twin early on. In 2003, the first randomized trial looking at a different intervention for twin-to-twin transfusion syndrome was published by Young DeCrest and Eville, really looking at entering the uterus using laparoscopic type instruments to visualize those vascular communications and lasering them. This was kind of going on in conjunction with Quintero's work here in the States. The benefit was is that this was done in Europe. They really were able to randomize it. There were only, I think, 3 centers in Europe that were participating in a fetoscopic arm of it. They also have a different setup with their manufacturers of equipment. So if they did a case, the rep from Storch was in the room with them. They would discuss how the case went, discuss what tweaks they wanted in the instruments, and within about 2 weeks, he would turn around a new instrument and bring it to them and be able to alter that kind of on a real-time basis. The FDA doesn't let us do things like that, so we weren't able to do that here. And in the States, we were still using larger laparoscopic instruments at the time. When they randomized it, they had an N of 72 in the laser arm. At least a single survivor in 3/4 of those pregnancies. Overall perinatal survivorship of about 57%. Average gestational age of delivery 33. Neurologic injury only 5%. Amnio reduction arm, about the same numbers, but 51% single survivorship. Overall 41% with delivery a month earlier. One of the big outcome differences was if we were able to separate those circulations, only 7% of babies following loss of a co-twin had neurologic injury versus 35% in the amnio reduction arm. So we decided, like we do with most studies, that since it was done in Europe, we didn't believe it. And so we're going to repeat it here in the States. Tim Crumbleholm was a pediatric surgeon that now runs Denver Children's Hospital and is a very talented fetal intervention guru. But he decided that we'd do an amnio synthesis arm here versus the laser. Only put 20 in each arm. Showed a single survivorship of only 65% in the laser, 75% in the amnio reduction. Improved survivorship for him in the amnio reduction. And so this delayed the adoption of the technique here in the States for a couple of years due to his contention that there was no improvement with laser. He's now actually one of the busier laser centers in the country. So once he figured out that probably the difference in survivorship was the fact that those were his first 20 cases, he figured out that maybe we should do things differently. He went over and worked with the rest. So 75 to 90% survivorship of at least one twin is kind of the current ongoing results. 35 to 45% of pregnancies will have survivorship of both twins. If one twin dies after the procedure, we believe 7% of remaining babies will have neurologic injury. Problem is, this leaves 25% that neither twin will survive. So if you actually have the diagnosis of twin-to-twin transfusion syndrome, and if you happen to actually get to a laser center, of which there are only about 10 in the country, you still have a chance of 1 in 4 that you're going to walk out with no babies. And a chance over half that you're only going to have 1 baby. How do we do it? Fetoscopic technique, the main critical aspect, access to the gestational sac. Actually being able to get a 2mm scope or smaller into the sac and be able to visualize things. That was probably the most difficult part of the procedure. Once you're there, then just mapping the placentas and lasering those vessels becomes easier. Different sheets. Sorry, my PR slide from when I was in Minneapolis. We did our first case in 2008. So what happened for us was, after that study came out in 2003, we kind of hemmed and hawed around for a few years, not knowing what to do with it. We sent patients to Quintero, which meant that if you saw me in the office in Minneapolis and we diagnosed you as having twin-to-twin transfusion syndrome, our recommendation was that you went to the airport, you got on a plane, and you flew to Miami or to Tampa, depending on where he was at the time. And he might get you in the next day, or he might be able to get you in next week to talk to you about whether they could try to laser your pregnancy. There really were no treatments available until the neonatologist came to us and said, why is it your group can't treat twin-to-twin transfusion syndrome? We said, well, it's not what we do. And they said, well, figure out how to do it. So being a pediatric surgeon, I went to the Eurofetus meeting first we called around in the States, and we talked to Tim Crumblehome, and we said, we want to learn to treat this disease. And his quote was, you're just going to kill a lot of babies. Okay, that's good advice, but not very helpful for our patients. And not very optimistic for us. Nobody in the States would train us to do the procedure, even though we were seeing these things. So we took the time, went to one of the European Congress meetings, cornered Jan Deprest after a couple glasses of wine and said, we need to learn to do this. He said, nobody in the States likes me. You all don't believe my data anyhow. We had to do a few hours of mea culpa. We love the Europeans. This is great. We need to drop the borders. And he invited us to come for 6 weeks. Me and a pediatric surgeon went to Belgium for 6 weeks to learn to do just fetoscopy. And came back and met with the response again of, you're just going to kill a lot of babies. Which we really thought we might, which was a little unsettling. But what we told patients was, we haven't done this before. We can take you to the airport and get on a plane and fly to Tampa. Or we can do it here if you're like most of us that don't really have access to our own private plane to hop to Tampa from Minneapolis. And we had somebody, March 28th of 2008, that said, you're right, I don't have any way to get out of town, and I'll be your first case. We probably didn't sleep from about March 27th to March 31st because of nightmares and concerns over doing your first case. And it's really a little nerve-wracking. Over the next 8 years, we ended up doing a couple cases a year for the first few years. We got up to where we were doing about 16 cases a year last year. We had 64 total cases, and came up really with the same numbers that the Eurofetus group came up with, of about 90% at least one survivor, and about 50% twin survivors. Interesting thing to us was about 1/8 of the patients we were seeing as sent to us for twin-to-twin transfusion syndrome really didn't have twin-to-twin transfusion syndrome, or they didn't have it to the level that they needed to be operated on. So they were either a stage 0 or a stage 1. We could follow them conservatively, and they didn't need to have any intervention, which saved them a trip from going to Florida. But it also allowed us the information of what's happening with the disease. There currently is a registry that has just been started trying to follow the natural course of monoamniotic twins, with a separate registry looking at laser interventions in the States. But at this point, we really don't know what happens with those cases. Let's see if we can make this work. So a little disclaimer, we pirated this video from some people we worked with in France. This was not our idea of sterile technique, and they have a little different healthcare system and don't necessarily do the same things that we do. We did this in an operating room, gowned and gloved, just like any other OR procedure, under a spinal anesthetic. They used a local, and did it in kind of a procedure room. So you enter the sac. Most often we were using a 2mm scope through about a 12 French cordis. The line here and the difference in the colors of the placenta, this is where the membrane is collapsed up against the donor's side of the sac. All these vessels are crossing that inner twin membrane. There, these toes, feet. So again, the vessel comes down, crosses the inner twin membrane. Average number of vessels that communicate between a baby that are able to be mapped is somewhere in the neighborhood of 7 to 8 vessels, but can range anywhere from 1 to 2 up to about 16 vessels that will cross and communicate. You enter into the recipient sac because that's where the polyhydramnios is. Get the scope in there, find where the umbilical cord insertion is, and then track each of the vessels out from the umbilical cord to where it either returns back to the umbilical cord insertion or it crosses the inner twin membrane in anastomosis with the donor. Once you've mapped all of those vessels to determine which ones are actually communicating with the donor, using either a YAG or a diode laser, go in and try to obliterate those communications. You have to be within about 5 millimeters of where the vessel is, but if you touch the vessel will rupture, which is a bad day. So, mom's breathing, babies are moving around, you're kind of rocking with the ship, trying to get close to these vessels and coagulate them with the idea that you're going to stop the blood flow across. If we do injection studies post-laser, we find that you probably interrupt the flow between those babies about 2/3 of the time. Probably 1/3 of these babies still have residual anastomosis, but recover from their twin-to-twin transfusions. So we don't know how that change in flow can result in everything fixing when they're still communicating. And certainly complete separation isn't always required. Takes about 40 or 50 of these cases until you're up on the part of the curve where your outcomes are going to be, wherever your outcomes are, based on what you're doing. The first 3 to 5 are a little nerve-wracking. At the end of the procedure, you take off extra amniotic fluid like an amnio reduction. Do otherwise, so moms feel much better kind of at the end of the case. How often does this need to be done? You know, we estimated the numbers for Minnesota. If you believe that 3% of twins are going to actually be involved in this. By the time it works out, and you go through twin gestation, number that are identical, number of monodi, incidence of TTTS. For Minnesota, we were guessing there should be 75 cases per year. In the country, we were guessing there should be 7,500 cases a year. I can tell you right now, there are only about 150 of these cases done annually in this country. So either the incidence isn't as high as we think it is, or more of these are being lost in community hospitals and not making it to laser centers to be treated, or probably both, and it's some combination of those things. So hopefully our registry will tell us at some point what the actual course of this disease is and what the proper treatment of it is. Again, our goal, this is one of the first cases that we did at these babies' 1-year birthday. Probably a blind pig finding an acorn, the fact that we got 2 babies out of this case, but better to be lucky than good. Again, monodi twins, dichorionic twins, mono twins, cords abutting each other with no membrane between them. And for those people that wanted references to kind of refer to if you want to have more information on any of this. The ACOG practice bulletin actually on multiple gestations is a great reference to look at what are those risks of the multiples. And it's useful in counseling those patients that are going to come to you with multiples so that they know what their risks of prematurity are and those types of things. North American Fetal Therapy Network is a group of about, it's probably up to 15 or 20 fetal therapy sites across the country that we met twice a year in an effort to try to come up with some sort of standardization of what's going on in fetal therapy. Fetal therapy is kind of split half and half between pediatric surgeons doing the procedures and perinatologists doing the procedures. Who owns that that business in different centers depends on kind of who started it. We were the only center that was started jointly by both specialties in an effort to share it. And I can tell you, when I started doing the fetoscopy, I probably hadn't touched a scope in 6 or 8 years, and my pediatric surgeon colleague was a minimally invasive pediatric surgeon and was very good with the scope, and it was very helpful for the first few to get my learning curve back up there. Other places have done tremendously well with just pediatric surgeons. Tim Crumble Home in Denver, UCSF Center was founded by pediatric surgeons and has done very well. Others do very well with just perinatologists, the Baylor Center, the UT Houston, or the CHOP program in Philadelphia. So if it's something that interests you and some desire to get involved in fetal therapies, certainly let me know. We can talk about it. There are fetal therapy fellowships after you're done with your OBGYN residency or after you're done with your perinatology fellowship, depending on which one it is and what order you want to do things. Pediatric surgery doesn't have those fellowships yet. Questions about multiples or twin to twin? Or yes, Daniel?
So what's the surgical stage that you would, or the stage that you would go for surgical intervention?
It's in flux. Okay, so we didn't operate on anybody that was a stage 1 or below, unless they had symptomatic polyhydramnios that failed amnio reduction. So if you were just a stage 1 massive poly and we drained it off, and within a few days to a week you were back to where you couldn't lie down or you couldn't tolerate it, then we would offer you surgery. Or if you had cervical shortening. And the issue with cervical shortening is the idea is that the uterus has grown too big from the polyhydramnios, it's resulting in too much pressure, your cervix shortens. If we can get rid of that and stop that from occurring, then maybe it'll help the disease. If you look at the actual results of fetoscopy with a short cervix, the delivery time seems to be about 10 days. And so it's a terrible procedure, and it's a terrible disease when you get to that point. But stage 1 with symptoms or short cervix, we would operate on. Stage 2 and above, we would operate on. There's a randomized trial looking at intervention for stage 1 that was just presented at the SMFM. It seems to trend towards improvement with stage 1 intervention, but the recommendation was just to do a larger trial, so we don't have definitive answers yet for stage 1. My take on it is that these are pregnancies that can be followed in a local community, ideally by a perinatologist, every couple of weeks until they get a discrepancy. When they start to see an amniotic fluid discrepancy, it's somebody that really needs to get to a laser center, at least for an evaluation, so they know where to go back to when they get to the stage that they need to be operated on. It really needs to be worked in conjunction with a laser center. So we had a lecture in Minnesota. We had probably 6 other perinatal practices within the region, and you just keep open lines of communication. We'd see them once, go through what the disease is, what the progression might be, send them back to their local provider, which often was 3 to 6 hours away, and they would see them once or twice a week, call us with the results, and when it was time, they'd come and get us. Yes, sir.
Is there a, so you're a local perinatologist monitoring, is there a cutoff or when you start suspecting twin transfusion in terms of amniotic volume or weights? I always hear about weight discrepancy, but
they like to harp on weight discrepancy. More often than not, if you see a weight discrepancy between monochorionic twins, it's selective intrauterine growth restriction, and it's not related to that imbalance in the placenta. In those that you have the oli-poly syndrome, so you have one baby with oligohydramnios, and you have to have the other baby with polyhydramnios, then you're trending towards twin to twin. So at what point do you get worried? Anytime there's a fluid discrepancy, it should come into your mind that this is a possibility. and it changes when you bring them back. So if, no fluid discrepancy, everything looks good, come back in 2 weeks. If you saw them 2 weeks ago and everything was great, you see them today and you've got 2.5 centimeters of fluid for one baby and you've got 7.5 for the other, probably ought to see them again in a couple of days. They're probably trending towards having an issue that needs to consider intervention. So a lot of it becomes a moving target. There's really not a set amount. There are papers looking at what is the frequency of ultrasound monitoring that's most appropriate. It seems that 2 weeks is adequate for normally distributed amniotic fluid volumes. The Twin-to-Twin Transfusion Foundation, which is on the web, and is well subscribed to by people with monoamniotic twins, says you should scan them every week. So patients come in and say, I want weekly scanning. And you have to kind of talk them down and get to a reasonable compromise. Yes, ma'am.
What's the risk of PPROM, and is it similar to an amnio in that you kind of expect it to resolve if it does happen?
Actually, the risk is probably in the 10 to 15% range, so much higher than an amnio. Whether you get resolution or not, not to the extent that you will with an amnio with a 20 or 22 gauge, because you're putting in a 12, either a 10 or a 12 French cordis into the uterus. So you do get 10 to 15% that will rupture at some point after the case and prior to term. You get about 3% that will leak into the abdomen from the uterus. You get about 1% that require transfusion from having had the procedure. Preterm labor and those types of issues is probably again in that 10 to 15% range. So not a benign case at all. It certainly contributes to the 25% that won't have any take-home babies. All right. Thank you all.